Learning Plan 1, Part 8, it just never goes away. It's always so much fun. So, onset, peak, and duration. We kind of talked about some of these already. And the names, the terms are, I hope, self-evident. Onset is the time it takes the drug to elicit a therapeutic response. So, you swallow a pill, it's not immediate, usually. Usually it takes time. And that length is the onset period. Most oral medications take 30 to 60 minutes to get into the body. So you give a pain pill, you're going to have to check its effectiveness in about an hour. If you check it after 15 minutes, it's still being dissolved and absorbed into the system, right? We worry about absorption. We worry about things that affect absorption time, then the distribution through the body. So there are many different factors that affect this. Peak is the onset is when things start working, and of course peak is when you get your maximum effect. And again, that there's a time frame for that. Every drug has a different onset and peak, and then duration is how long there's enough medicine in the system to have a positive effect. So onset, the beginning of the positive or intended effect. Peak is when you're at the maximum, and duration is how long before the effect goes away. A lot of times pain medicine has a duration of, 3 to 6 hours. You'll notice it based on how often your orders are, how the orders are written. If you can give a pain pill every 4 to 6 hours, you can probably guess that the duration is somewhere in that 4 to 6 hour range, because they usually won't prescribe things too frequently. Now, remember, we talk about how quickly a medicine is absorbed and how quickly it starts working. The greater the concentration, the faster the effect. So an IV medication, the onset is very fast, sometimes almost immediate. There's a medication called adenosine, and that is used to hugely slow the heart rate. It's given for things like rapid supraventricular tachycardia. Sometimes people get a heart rate in the 220s, 230s, and they don't tolerate it very well. So we give this medication called adenosine, IV push, fast IV push. It has a half-life of 6 seconds. Remember we talked about half-life? That's the time when half the medication is out of the system. So we give it very quickly. 6 seconds, boom, half of it's gone. But that means the onset's almost instantaneous. Sublingual nitroglycerin tablets. Onset is very quickly. Remember, the endothelial lining of the mouth rapidly absorbs some medications, so that can be very fast. Tylenol takes up to an hour before it starts to work because it slowly gets absorbed. So onset, when things start. Peak, when you get the maximum effect, and then duration, how long you can expect the effect. These are very important concepts. You will need to know this for all the medications you administer. We look at some other concentrations. The minimum effective concentration is the minimum amount in the body before you have an effective dose. The minimum toxic concentration, that's the amount when toxic effects begin. So you minimum effective, minimum toxic is your therapeutic range. If you don't give enough to hit that minimum effective concentration, you're giving medicine that does nothing. And a common thing there would be Coumadin, warfarin. Remember the lab that we check for Coumadin is called the ProTime, PT or INR, the International Normalized Ratio, and frequently it's called PT/INR. We look at that, or the doctors look at that, to determine if they're giving enough to hit that minimum effective concentration. So if a person needs 5 milligrams of Coumadin and they only are given 2, they're taking Coumadin and it's having no effect. Nothing. They may as well not take anything. So you need to make sure you give enough to hit that minimum effective concentration, but not exceed that minimum toxic concentration. There's a plateau or steady rate concentration, and that's when you are wandering in and amongst the minimum effective and the minimum toxic. And when you can stay in that range, you will have continuous effective doses. Not everybody needs the same amount of medication. That's part of where the art of medicine comes into play. 2 people, same exact size, age, gender, will have different genetic makeups. And some will need more, some will need less to stay in that range. Right? Peak concentration, that's when you have the maximum of bioavailable medication within the body. Trough concentration, we talked about this when we were talking about vancomycin. Vancomycin peaks, vancomycin troughs. And ideally you want the trough never to go below the minimum effective concentration. Slide 49 shows you just a graph looking at the minimum effective concentration, minimum toxic concentration, and how it looks with multiple oral doses. You will not be having lab draws for most drugs. Warfarin, or the proton INR, is one that you'll do frequently. DIG levels, vancomycin levels, those are common medications. Potassium levels. If a person's receiving potassium supplements, that's another lab that you will frequently see, and you must know their potassium levels if they've had a potassium draw. You must know that result before you give either a potassium wasting diuretic or potassium supplements. We, the instructors, will ask you if you know that potassium level. If you don't know the potassium level and they had one, that's bad. You must know those numbers. They're readily available. We have to monitor medication effects. You can't just give pills and say, see ya. You have to monitor if we're getting an effective result. So, pain meds, what would be the effective result? Reduction in pain. Well, if a person's had surgery, do we expect pain to be 0? Remember, pain is measured on a scale of 1 to 10, 0 to 10. 0 being no pain at all, 10 being the absolute worst possible pain imaginable. Post-surgical, do you expect a pain of 0? You shouldn't. The person has had surgery. They shouldn't expect to have a pain of 0. You shouldn't either. It can be reduced. It won't go away until the surgery heals. If you have a headache, you can expect a pain to be 0. May not always be achievable, but it could be achieved. Blood pressure medications. How are we going to check for therapeutic action? We're going to check blood pressures. We're going to check heart rates. Some blood pressure medications, we need to actually check a heart rate before we check a blood pressure. A beta blocker is one of those. You will always check the heart rate as well as the blood pressure for beta blockers, because beta blockers reduce the heart rate, and that is how it controls blood pressures. So with like an ACE inhibitor, you just need to check blood pressure. Beta blockers, you must check a heart rate also. You must check the heart rate in addition to blood pressure. Make a note of that, because when you give a beta blocker with me, I'm going to ask you, what's their heart rate? If you don't know, that's a problem. We're going to look for the unintended actions, the adverse reactions, the side effects. If you're giving antibiotics, a very, very common side effect and adverse reaction is nausea, vomiting, and diarrhea. Those are not allergic reactions. Remember, allergic reactions are rashes, hives, itchiness, swelling, airway that closes up, a drastic drop in blood pressure. Those are allergic reactions. Nausea, vomiting, diarrhea, the most common side effects of any antibiotic. But we're going to have to monitor for that. Now, if a person develops those, we are not going to immediately stop the medication. We might notify the doctor, but we're not going to stop it because those are predictable side effects. We're going to monitor the patient's condition. We're going to, if the person has had surgery and they develop a temperature of, say, 100.5, their temperature before surgery was 98.4, and after surgery it's 100.5. Oh, were they having see, I like to get the really, animated there. Are they having an infection? Probably not. That's a surgical fever. So how are we going to treat that? Are we going to give them Tylenol? No. Cough and deep breathe. They're going to cough and deep breathe, and that will drop their temperature. But later on, if they're having a little bit of an elevated temperature and a headache, sure, give them some Tylenol. And then check the results. How are they reacting to it? Are they developing a tolerance or dependence? Now, these are some very key concepts here. Tolerance is the capacity for enduring large quantities of a substance without negative effects. Okay, now get that. The capacity for enduring large quantities of a medication without negative effects. Now, this is not common for most people, but people who have chronic pain, they frequently develop a tolerance for pain medicine without having that sedation or the nausea or anything else. That is not dependence. Very different. Tolerance is simply your body is used to it. It expects it. It's okay with it. It has learned to tolerate and accept that medication without giving bad side effects. We're going to look for any interactions, any drug-drug or drug-food or drug-herb interactions. We're going to look to make sure they're in that therapeutic range. And we're going to just see if there's anything bad that happened. We're going to look for side effects. Remember what are side effects? What's the definition of a side effect? The undesired but usually predictable pharmacological effect of the drug. Again, with antibiotics, nausea, vomiting, diarrhea. With painkillers, drowsiness. These are predictable effects, but they're not really what we're looking for. We're gonna monitor for that. We're not going to freak out. We're not going to worry or panic because we can predict those results. How about a toxic effect? Do you remember what the toxic effect is? We talked about that a couple slides ago. These are effects that are caused by the drugs that can result in poisonous injuries to the patient. Again, too much painkiller and their respiratory rate drops. That's bad. That's a poisonous effect, and we want to make sure that doesn't happen. Another effect is an idiosyncratic effect. Now, idiosyncratic effects are odd. Let's just call it that, odd. Idiosyncratic, whenever you see idio in front of a word, it almost always means unexpected or unknown. So an idiopathic disease is a disease that has a no known cause. So idiopathic seizures mean person has seizures for no underlying cause. They don't know. An idiopathic side effect is a completely unexpected or opposite reaction to what should be there. Here's a living example. Me, for painkillers. Most people, when they get painkillers, remember what happens? The pain goes away, and then they get drowsy. That's a side effect. It's a predictable but undesired effect, right? For me, my pain gets reduced, and then I am wide awake. Wide awake. It's frustrating when I have bad pain in my knees and I need to take my painkillers. I will be up all night long. That is an idiosyncratic effect to painkillers. It's not a tolerance. It's not a dependence. It's just my body, my genetic makeup says painkillers mean wide awake. So it's frustrating. How do you suppose I handle that? How would you handle that? What would you suggest? What would you ask the doctor for if your patient were complaining of an idiosyncratic effect to painkillers? Are you going to tell them not to take the painkillers? I hope not. So what might you do? Well, in my case, my doctor has suggested that I pre-medicate with Benadryl about an hour before taking the painkillers. That gets me drowsy, so when I take the painkillers, it does not get me all wound up again. It just keeps me at a steady level. I'm able to sleep then. So those are odd reactions that you might see because people are different. And everybody reacts to medicines differently, and it's not always predictable. That's why you get idiosyncratic reactions. So we've talked about onset and peak and duration and the minimum effective dose, the minimum toxic levels. Now we're looking at come back in the next part of this lecture as we continue this exciting look at pharmacology.